Are there other people standing up here when you introduce them, or do they wait to see?
Well, Taylor and India stood up here together.
Oh, okay. Okay.
They're supposed to get chairs up here for the panel. I got to tell them to do that. I'm going to go out after this break and tell Donna, like those chairs we had yesterday, they were supposed to have some up here for everybody to sit up here.
When after our talk, is there another talk before lunch, or is
No,
this
this is it.
Okay.
And then sometime after we eat, let's go ahead and look and see if that flying stuff is there.
Okay, the one picture that you want to do flying, we can't, because it's one picture.
It's one picture.
Yeah.
Okay, gosh, I hope I can read what it says then.
Yeah, I would just go with your gut.
Yeah.
Half of what I'm going to say is improvised anyways.
I like improvising. Is everybody back in? Pardon me? What? Okay. Has everybody gotten scanned in for this session? If you have not gotten scanned, please raise your hand. I got it. If you've not gotten scanned, please raise your hand. Okay, we're going to go ahead and get started with our last morning session, please. Hello? Hello? Everybody? So we're trying to catch up a little bit because, of course, every presentation we had this morning was very important, and there was a lot of Q&As. But we also feel that this is important, so we want to be able to get the speakers in there and have them tell you what their expertise is about pain. And our first speaker is going to be Daniel Sopp, who I introduced yesterday as our digital dynamo. Daniel is a biomedical engineering PhD candidate with over 15 years of technical and computational experience and over 10 years of data management experience in healthcare and research. He earned a Bachelor's of Science from Old Dominion University and a Master's of Science in Biomedical Engineering from VCU. And he's completing his doctoral degree in biomedical engineering with a focus on objective pain measurements, which has been his interest since he's been here. He is currently the Senior Clinical Research Analyst for several sickle cell disease studies that are funded by the NIH as well as private sponsors. Mr. Sopp was also recently selected as a fellow by the Pittsburgh Intensive Training and Hematology Research Program, which I have to tell you is pretty impressive, an NIH research education program that supports research education activities aiming to complement and/or enhance the training of a workforce to meet the nation's biomedical, behavioral, and clinical research needs, while enhancing the diversity of the biomedical, behavioral, and clinical research workforce by recruiting individuals with specific specialties or disciplinary backgrounds to research careers in biomedical, behavioral, and clinical science in order to better understand biomedical, behavioral, and clinical research as its implications. Mr. Sopp.
Thank you. That was a lot. So today we're going to talk about pain in sickle cell disease. Dr. Sisler and Dr. Smith touched a little bit on it yesterday, and today I'm going to give a brief overview, and then we're going to go in depth about prescription and chronic pain, acute pain, with Dr. Smith and Lupato. Pain in sickle cell disease, like we know, is very unique. It's the hallmark of sickle cell disease, and it's very different for every single patient. It doesn't affect everyone the same, and it affects every single part of the body. Before I go on to the next slide, I wanted to bring a hammer today and break somebody's knee to see what it feels like, and then try to translate that for pain. But the optics on that are not great, so I'm going to ask you a question. If you could raise your hand if you've ever given birth. Okay, nice. Giving birth, good. What about if you've ever had kidney stones? Nice, nice, nice. Ever broken a bone, anyone? All right. So can you imagine what it feels like? You know, imagine you have given birth, you've broken a bone, you've had kidney stone. What did it feel like? It was painful, right? That's how sickle cell disease patients feel. And imagine telling somebody that you have that pain and they don't believe you. How would you feel? Yeah, imagine you can't predict when that pain happens. How would you feel? That's what sickle cell disease patients feel every day when they have vaso-occlusive crisis. Sickle cell disease hurts. It's extremely painful. And with sickle cell disease pain, you can experience it on virtually almost every part of the body. It does not discriminate. Pain occurs everywhere on the body at any given time. There is no specific time of the day, time of the month, time of the year when a crisis can happen. It just happens. Sickle cell disease pain is often compared to cancer pain, although it's very different from cancer pain. This slide highlights the differences between sickle cell disease pain and cancer pain. And I'm going to go through a little bit of the details. For cancer pain, it's usually not ischemic. I mean, that means you have good blood flow, you have good oxygen going to your organs, but you also experience pain. Pain is very continuous. There's excellent care for patients that have cancer. It's very predictable, almost depending on the type of cancer that you have, the pain can be predicted. And it often happens late in the disease. There are very many objective signs to measure what your pain might be like, to get an idea of how your pain can be treated. And almost everyone in your healthcare system respects you or feels for you when you have cancer. With sickle cell disease, low oxygen going to your organs leads to organ damage. You can't predict it. When you tell somebody that you have pain, they don't trust you, they don't believe you, they think that you just want medication. It happens unpredictably, and it happens throughout your entire life, whereas with cancer pain, it only often happens when you have the condition. With sickle cell disease, you also have frequent emergency visits, frequent hospitalization, which leads to a lot of costs for healthcare systems. And it doesn't discriminate children, adults, and sickle cell disease patients also, or patients with sickle cell disease have spotty medical care because of the fact that there are not enough specialists in sickle cell disease, depending on the region of the United States or the world that you live in. And they tend to use the system a lot. Sickle cell disease pain, a patient with sickle cell disease experience pain like nobody else. Again, care is not great. Patients tend to use opioids a lot. It starts when he wants to, it stops when he wants to. You can't predict it, you can't count it, and it affects multiple organs in the body. And the hallmark of sickle cell pain, or the hallmark of sickle cell disease, is vaso-occlusive crisis. This set of slides is going to tell us what vaso-occlusive crises are and why they happen. So I'm going to show this, which is a simple illustration of good red blood cells cells that have been affected by sickle cell disease and vaso-occlusion on the right here. And we have a prop for you today. It's, something really nice, sexy. So I'm going to take these oranges and I'm going to put on the top here. Can you tell me what's going to happen when I do that? What does that simulate? Simulate. What is it like? Healthy, good red blood cells. All right. Now let's take these delicious bananas. What's going to happen? Sickle cell. That is how a vaso-occlusion occurs. You have the sickle cell, they get stuck. All right? So, thank you. It's all right. The next slide is just a slightly complex explanation or illustration of what I just demonstrated. Although it seems simple, it doesn't always occur as simply. There's a lot of chemicals that get involved, a lot of organs that get involved. And we can go back to the talk that Dr. Luparo gave yesterday, where he was using chairs to show how when you have oxygen, some live, some don't live, and your cells sickle because they form a long polymer chain that then bends the red blood cell. This is essentially just an illustration of that. And this is an explanation. Again, normal red blood cells, they're like donuts, kind of like the orange. Sickle cells are shaped, like a croissant shape, somewhat like the banana. And this explains and shows how a sickle cell vaso-occlusion occurs. Essentially what it says is that red blood cells create hormones and molecules that help the cells to get tight together and form long polymers that then bend the red blood cells. And then when that happens, it occludes the vessels, which reduce how much oxygen goes to the organs, and which leads to organ damage and pain. It's unpredictable and can be extremely painful. So what is the impact of sickle cell pain and vaso-occlusive crisis? Dr. Smith talked a little bit about this yesterday, and I believe Dr. Cicero did as well. It's expensive. In America only, it costs $2.4 billion a year due to hospital utilization, whether it's emergency room visit or inpatient care. Patients with sickle cell disease are 7 to 30 times more likely than any other African American to go to the hospital, and 2 to 6 times more likely to visit an emergency room, which leads again to high cost for the healthcare system. It affects the quality of life and performance. I believe Dr. Cicero talked a little bit about this yesterday. You have a lot of pain leads to pain. Transition to adulthood is very difficult, which leads to decreased quality of life, hospitalization, you don't have enough support. And typically, patients with sickle cell disease lose about 12% of school year, 19.2% of children are held back at least one grade. It just goes to show how somebody's quality of life can be affected when they have sickle cell disease. The next slide really just shows the impact of function for children with sickle cell disease and adults with sickle cell disease. Essentially what this slide shows are results from a study that was done to see what was impacted for people with the disease or the condition. And you can see they have a lot of emotional functioning that is reduced, social functioning is affected, joint stiffness, their sleep is impaired, and they have a lot of pain. And again, patients that have a lot of crisis usually use the system a lot. By system, I mean the healthcare system, which leads to a lot of costs for healthcare. sickle cell pain also impacts mind and emotion. This is just slides to show a few statistics about how pain for patients with sickle cell disease impacts their mind and emotion. They have depression, anxiety, some abuse alcohol, some have stress, catastrophizing, somatizing, kinesiophobia. I believe Taylor was talking about a patient that was scared of, to use elevator. And we have others that rather use elevator, but they don't want to walk. They have poor self-efficacy and poor coping strategies. That impact on work. Dr. Cesar touched on this yesterday. Typically, the more crisis you have, the less likely you are to be on time at work, the less likely you are to have or hold a good job, because you have increased absenteeism, you have decreased productivity, which leads to decreased activity. You tend to be stagnant, and we all know the more stagnant you are, the more depressed you get. The more depressed you get, the more pain you get. It's almost like a vicious cycle, never stops. You get pain, you have depression because of pain, you get stress, you can't sleep, you get tired, leads to more pain, and then more sleep disturbance, more pain, more stress, more pain. It just never stops. So pain, it's its own disease. It's a condition that needs to be addressed. It's a condition that for which a lot of research is being done to fix, but it's not yet completed. Sickle cell crisis has long-term impact on organ damage. When we think about it, when a crisis happens in a patient with sickle cell disease, it's typically because not enough blood or oxygen is flowing to an organ, and when that happens, the organ gets damaged. And if that happens enough, the organ can get to a point where it's not functioning anymore, and that's when we typically have gallbladder removal. You also have AVN, avascular necrosis, and so on and so forth. So this slide just highlights a few of the damages that can happen to an organ for patients with sickle cell disease. With that, I have a question for you guys. Vessel occlusion leads or contributes to which of the following? Everybody pay attention. This is all I got. Dr. Ricardo? Anybody have any questions?
So you should see what I'm talking about today. All right, so it's important to understand that when a patient comes to you with pain, whether it's in your clinic or in the emergency room, they probably have done a lot of trying to relieve that pain before they come to you. Some of the things they can do: self-help, home remedies, really relying on their social support system, getting help with just their activities of daily living, so actually trying to limit their activity. And then at some point the pain gets so bad that they need help. All right, we have some nice pictures. So obviously, like Daniel talked about, that there's really this vicious cycle with pain. And what patients experience, there's a vicious cycle within themselves about how the pain impacts their life. But then there's this vicious cycle that they experience in the social setting or out in the community. So because of pain, because that's a primary manifestation, whether it is sickle cell disease related pain, pain from back pain, pain from whatever it is, there is just a negative response that people get, anybody gets, almost from the jump start. Maybe with the exception of pain that the person hearing the complaint truly understands and has experienced. But certainly in healthcare, there is this negative response. And so individuals have to deal with the negative attitude that they get from the healthcare system. And what they experience, when I heard a patient tell me that before she goes to the emergency room, she has to really try her best to get dressed, look appropriate, wear nice clothes, look like she's this upstanding human being, so that when she goes to the emergency room, they're more likely to listen to her. And so imagine that, trying to put on your makeup and put on high heels so that you can actually get treatment. And then obviously there is patients who who have disputes about their pain management with the medical staff. By the time you are 18, 20, clearly when you're in your 30s, you know what has worked. And telling a doctor that this is what works, this is what doesn't work, as a doctor, unfortunately, is this big red flag, like, uh-oh, drug seeking. And so now you get into a dispute. And God forbid that gets documented into the chart. Then that just lingers on. And so that dispute then becomes another dispute when you see the next clinician who then looks at your chart. And it just spreads. That's the experience that they're having. Now, to worsen that, we have an opioid epidemic. So you had the way things were, and now on top of that, there is this national crisis. How is our government dealing with it? Well, I would say that there's a plus and there's a negative. The plus is we are now beginning to identify that it is a crisis, and it isn't a crisis of lack of morality or lack of willpower or a problem with people who are morally degenerate. It is a problem that is a medical condition. It has factors that have worsened it, overprescribing, how the pharmaceutical industry has affected prescribing, but we're beginning to understand that. Sadly, it took this long, and part of it is because now it is affecting white people. And it is affecting, interestingly enough, white females. They are suffering the brunt of this opioid and heroin epidemic. But put that aside, now we understand that this is a disease. Well, what are we going to do about it? We're talking about cutting down on arresting people and throwing them into prison. Great. There's pushback on that. But also, we're not talking about trying to treat it robustly and trying to create a healthcare system that is really going to treat an epidemic. And so whenever some politician says, I want to address this, but at the same time I want to do away with the Affordable Care Act, that makes absolutely no sense. So it's a plus and minus. And so we can see here, as the years have gone by, opiate prescribing has gone up, and opiate-related deaths has also gone up. And we've also seen that in comparison, when we compare it to deaths related to motor vehicle accidents or firearms, more people are now dying of drug-related deaths than firearms or cars. So this really is truly an epidemic. And so because of that, prescribing opioids in our patients, to our patients, has become this big spotlight. And there are obviously benefits and there are harms related to opioids. They've always been. And because of this epidemic, we are now being forced, but we should do this, having to educate our patients about the risks and benefits of opioids. I don't think there is any question as to what is the benefit of an opioid in sickle cell disease. But nobody has sat down and said that if we put somebody on chronic opioids meaning taking pain medications every single day for the rest of your life, has this positive effect. And what is a positive effect? Makes you live longer, whatever it is. That research hasn't been done. The research has really been focused on short-acting opioids to treat what we think of as a kind of episodic pain crisis. But the reality is, we know that that's not all of sickle cell disease. And in adults, that episodic pain crisis becomes chronic pain. And Dr. Smith will talk about that. Well, how do you treat chronic pain? Well, it makes sense that you would give them a long-acting opioid. Is the evidence there that that is beneficial? It is not. But that's what we do, mostly because there's no other option. But I think it's important to know that when it comes to long-acting opioids, we are giving a treatment, and maybe 20, 30, 50 years from now, we'll have an answer on how effective and how wise that was. But just to say don't do it because there's no evidence, well, then the patients are going to say, then what's the alternative? And we don't have the answer. So obviously, what is the argument for giving an opioid, chronic opioids, for chronic pain and sickle cell disease? Well, obviously, we know that pain is subjective. We understand that pain has historically been undertreated in individuals with sickle cell disease. But that being said, we also understand that pain has significant consequences. Sorry, opioids, especially chronic use of opioids. Patients can obviously become addicted. I'll talk about that. There are true harms that can happen in the body when they're on high doses of opioids. We know that high doses of opioids can promote sleep apnea. In men, high doses of opioids can decrease testosterone level. We know that high doses of opioids given chronically can actually heighten people's pain sensitivity and make their pain worse. So here it is, we are now trying to balance pain management, particularly in chronic pain in adults with sickle cell disease. And when we look at what patients are taking, many patients take short-acting opioids, but there really is a large amount of patients that are on long-acting opioids. So we really we've passed where the evidence is, and we are managing pain with long-term opioids. And before we have any proof that this is the right thing to do from a treatment and an efficacious standpoint. But again, it's because we don't have any other options. What's important is with sickle cell disease, what we see is that the sicker the patient is, the more complications they have, they tend to be on more opioids. So whether it's somebody who has an ankle ulcer, and it took me a while to appreciate how painful that little tiny spot on that patient's ankle was, because patients would repeatedly say, this is worse than any crisis I have had. And it is just there. And it's just there. And it looks tiny, and you're like, okay. Obviously, we talked about avascular necrosis yesterday. So if you have avascular necrosis, you're more likely to use opioids. Priapism, we talked about that as well. So what we see is individuals with sickle cell disease who have these very serious complications, it adds on to their pain. And this is not talking about their crisis. So they have all of this pain, plus on top of that, their episodic sickle cell crisis. And sometimes it can be hard to differentiate the two. But essentially, the sicker, the more complications you see in sickle cell disease, the more opioids patients take. And that is appropriate. It isn't inappropriate, it is appropriate. But the more opioids you take, the more likely you are to have complications from the opioids, unfortunately. What is interesting to know, and it took me a while to appreciate, is that just because somebody goes to the emergency room a lot doesn't necessarily mean that that is the patient that uses the most opioids. In fact, we have some patients that get enough opioids that they manage their pain at home. They don't ever have to go to the emergency room. And it is an interesting, I think, not a verbal argument that me and Dr. Smith have, but it's almost like this philosophical conversation of, do we give somebody enough opioids that they can just manage all of this pain at home and keep them out of the emergency room? Or do we want them to come to the emergency room? Do we want to lower the opioid burden and allow them to then have to come to the emergency room and get episodic opioids? You can make an argument on both sides. Many patients will say, no, give me all the opioids. Some patients will say, that just has so many problems, I would rather go to the emergency room. And patients are trapped in that conundrum because they will literally hear conflicting advice from me and Dr. Smith. I will say, oh, don't take too many opioids, go to the emergency room. Dr. Smith may say, take all these opioids, don't go to the emergency room. And I think it's important that we are honest about that, because we don't know what is the right thing in every single patient. This is a very sad slide. This is a drug that is called Rivapanzo, or I should say it was. And essentially it was a drug that stopped the stickiness of the cells in the blood vessel. And we thought it was going to make it. It did not, as far as its primary endpoint. But what we noticed is that the patients taking it actually took less pain meds. And this is sad because I personally think that there is a space in sickle cell disease for drugs whose sole purpose is to relieve pain in such a way that it allows individuals to take less opioids. Maybe it doesn't cut down on how many crises you have a year. Maybe it doesn't cut down on how long you're in the emergency room or the hospital, as the administrators would love. But it simply means that instead of getting 360 oxycodones a month, you can get 120 a month and do just fine. If somebody would create a drug like that, I think the FDA should approve it. I don't think they will, but it is sad that we haven't talked about that being a niche within the sickle cell treatment. But I think we have to, as more people live into adulthood and we continue giving more opioids to more people. Now, obviously we know that many people are dying from it with this opioid crisis. Well, the good news is that we're not seeing that in sickle cell disease. And that's important. Yes, we are giving large amounts of opioids to individuals who have sickle cell disease, but we are not seeing this epidemic of our patients overdosing. And that is something that isn't known, because we just assume that if opioids are killing people, oh my goodness, this person gets how much? Well, my goodness, this is not right. Now, patients will overuse and underuse opioids. So that patient who gets however amount they get, sometimes they'll overuse it, sometimes they'll underuse it. And it's very interesting why they underuse it. And I've had patients personally tell me, obviously, I underuse it when I'm coming to see you because I'm driving. I underuse it when I have some function. I have to go to school to talk to my kids' teachers. I underuse it. One interesting one, which will come soon, is I underuse it when it's during the summer and the kids are all at home because I get too sleepy, and then they take advantage of me. I underuse it because of the way my family talks about me. So here is, we are giving them the pain meds, but there are all of these reasons why they're underusing. And then when they come to the emergency room, what they hear from the emergency room doctor is, Dr. Lopata just gave you all these pills. I know you filled them 2 days ago. Why are you here? Obviously, there are reasons to overuse it. Pain, just significantly intense. Really wanting to avoid having to go to the emergency room. Just that being the last thing you want to go to. And saying, you know what, I'm going to take as much medication as I just get tired. If I can avoid going to that ED one more time, I'll do it. And then obviously, people are human. So people begin to misuse. People are careless. And that's something we'll talk more about. This is the one where, if you look at the third one, where somebody said they don't take that many opioids because they feel drowsy and they feel like they can be taken advantage of. Obviously, patients are concerned about their use. And that's also important to understand. We almost think that the patients want to have all these meds, that they want to be leaving with these large prescriptions, but they don't. And they are concerned about their use and their dependency. And the more I started educating patients about the harms of opioids, I was surprised at how interested they were at hearing what I had to say. Because not until long ago, I thought they did not care. It's simply because I just didn't take the time to educate them and learn what they were concerned about. They are concerned about that. Unfortunately, people do misuse opioids. And chemical coping is probably the biggest thing we see with any population of patients on opioids, whether it is cancer pain, sickle cell pain, low back pain. Because you have a chronic condition that just makes your life either shitty or just pure hell. And if you have a medication that can take care of your pain and your anxiety and help you sleep and dull you from all of the life stressors that you have to deal with, you're going to take that pill. And people shouldn't then look at you and say, you're a drug addict. You're doing something bad. It has negative consequences, but this is humanity. This is humanity. And they have a condition that has all of these other implications. And it is very easy to go from taking medications appropriately to chemical coping. And it isn't a sign of somebody being a moral degenerate. In the US, we are all using drugs. I mean, I got my caffeine there. And there are some drugs that are legal. There's some that are becoming more legal. And there are others that are illegal. But the reality is we are all using something. We're all doped up on something. Not esoteric. Let's see what else I want to focus on. Let's talk about some definitions, because this I talk to my patients about. So tolerance is something that patients suffer with a lot. This is where, after repeated use of an opioid, the dose that you were able to take that managed your 6 out of 10 pain no longer manages your 6 out of 10 pain. And so now you have to increase the dose. Tolerance is almost universal in somebody who has to take an opioid on a daily basis. Because of that, people may think that that's addiction. It is not. Physical dependency. You take so much opioid, or you take so little, you take a small amount, but so often that your body gets used to it. Used to it in such a way that if you then stop taking the opioid abruptly, you experience withdrawal symptoms. Withdrawal symptoms from an opioid can be restlessness, can be irritability, it can be some pain, it can be as severe as having diarrhea, abdominal cramping. Physical dependency is almost universal. If I had to take an opioid every single day, I would be physically dependent. This is not addiction. Addiction, oftentimes, you have tolerance. You have physical dependency. But then there is the psychological component. So it takes those three things to then start to think about addiction. And when we think about addiction, there are other characteristics. Patients will crave the substance. There is a compulsion to use. Patients will continue to use the substance knowing that it is harming them. They will use it to the point where they are impaired or they just cannot control how they use it. The use impairs their physical ability and their social ability, that they're not able to do the things that they're supposed to do socially or that's responsible. Go to work, go to school. They get legal problems. They start to have issues within their social network, with their spouse, family members. And so the DSM, was it 5 now? 5? Has a very clear definition on what substance abuse is, and you have to meet certain criteria. It is very difficult to diagnose an opioid use disorder in somebody who is prescribed an opioid. It's easier if I'm not getting an opioid, but I'm just going to the street getting heroin or buying Percocet on the street. But in somebody that is being prescribed an opioid, it is very difficult. And one of the things I like to go back to when I'm trying to ask myself, is this patient who is prescribed an opioid, do they have an addiction? I try to figure out are they experiencing an inability to fulfill work and social obligations? And I try to hone in on that, because somebody who is prescribed an opioid by a doctor, they will have tolerance. They will have physical dependency. That's just a given. And so how else do I parse out what's going on? And I try to focus on, tell me more about your activity as far as your responsibilities, and are you able to use them, to fulfill them. What is interesting is that misuse of an opioid in and of itself isn't addiction. Many people misuse many substances that we take, but that does not mean that you have an addiction. And it is very easy to look at individuals with sickle cell disease who may overuse and underuse their opioids for reasons that they may not tell you, to see that as misuse. And even if you do come to the point where you're thinking this person is misusing their opioid, I think chemical coping is a misuse, if you think about just the definition of the word. But that does not mean that they have an addiction. You really have to dig deeper to make that diagnosis. So these are the criteria that you have to have an opioid use disorder. Tolerance, withdrawal. Right there, somebody who's prescribed an opioid would have experienced tolerance, and if they ran out of their opioid, they'll go through withdrawal. That does not mean they have an addiction, okay? Loss of control. So using more opioids than are prescribed. Well, I just told you that patients with sickle cell disease will overuse for valid reasons. So if you're going by this, okay, you're using more than I prescribed you. Inability to cut down. Well, I've sometimes tried to cut down on my patients' use. I failed. Do I give them a check on that? Craving is one that's very interesting. It's hard to parse that out. Are you craving it because you're in pain? Or is it the euphoric effect of the medication that you are wanting? That's very difficult to get out of somebody. But looking at their roles, are they failing at what they're doing? Are they neglecting their kids? Are they unable to come to these vital appointments that they used to come to? And so you're beginning to see that to make this diagnosis, you can't just meet the person for the first time and fill out a checklist and say, you have the diagnosis. You have to see them repeatedly. And one of the frustrating things when reading a psychiatrist's note is they'll oftentimes say, rule out depression, rule out schizophrenia, It's because they need to keep on seeing this patient over and over and over again before they can say, yeah, you know what, you really are having a reduction in your social activity. You can't figure that out just by seeing them one time. So it really takes time to really get that idea. The dynamic of opioid use is one where I would even draw a bigger circle around the green one. So you have appropriate use of opioid prescription. Then you have opioid prescribing. Then you have this overprescribing. And I would probably say that there was a time in America where the line between appropriate prescribing and overprescribing was probably like this, and maybe it's switching. But then within all of that, there are people that will misuse their opioids. And then within that big population, there's a subset of them that do have an opioid use disorder. And then within that subset, there are people who are at risk of having an opioid overdose. And trying to figure out where your patient isn't easy. And one of the things that I try to do is pay attention to the patient's prescribing, what they're telling me, and not quickly place a label. Because my goodness, if you put addiction in someone's chart, it is hard to get out. Very hard. Because people will, that is the one thing they'll type and paste, addiction. addiction. So, what are the forces that are changing how we practice? Well, the CDC years ago, not too long ago, came out and gave these guidelines. And they came out and said, basically, this is the amount of an opioid that is safe to prescribe. And we looked at our patients and we said, my goodness, our patients are up here. The CDC did not say, don't go past this level. They simply said, the data shows that if somebody's taking more than that, their risk of having an overdose is higher. Well, yeah, of course. The closer you are to sitting next to the fire, the more likely you're going to get burnt. Yes. But the way doctors read that was 200, can't go above that. So now we're going to take all these folks, we're going to work them down. Work them down. And we've had patients at the addiction clinic where I used to work at literally come in because their doctor just cut them off. And now now they have an addiction. I think the diagnosis of an opioid use disorder spiked after those guidelines because everything was fine, and then the CDC said something and it was read one way, and all of a sudden, oh well, if you're above that, you are an addict and we need to get you down. But those are the forces that we are dealing with. Hopefully, this is changing. As far as the opioid epidemic, that now we're beginning to see a shift downward in the overall prescribing. But what does that mean for our patients who have sickle cell disease? What does that mean when here you are, I'm telling you that you're going to live longer, I'm telling you that you have all of these complications that I can't reverse, I'm telling you that I still don't have a drug that can help you use less opioids, and the one that maybe could ain't on the market. I'm telling you all of this, and oh, by the way, as a nation, we're going to be giving people less opioids. Who do you think the doctors want to give less opioids to? It's that black face in the emergency room who's been there 5 times this month. That's who the nation wants to give less opioids to. It isn't the cancer patient. It isn't the patient that looks like the provider. It's the other patient. And while this is a positive thing, it makes me concerned for our patients. So here, war on opioids hurts sickle cell disease patients. In our database, there is a system that tells us how many opioids somebody is prescribed. And there are these factors that the computer system rates their risk of overdose. It basically rates whether the amount of opioids seems problematic. They look at how many opioids you're prescribed, the dose, whether you are given an anxiety medication, whether you go to several different pharmacies to get it filled, how many prescribers give you an opioid. Well, if you have sickle cell disease and you get an opioid from me, and then you see Dr. Smith, and then you see Micah, and then you see Caitlin, and then you go to the emergency room and you get a pain med there, which I'm fine with. You then go to the hospital and some resident discharges you with a pain med. How many providers is that? And that can happen in 4 months. So that number jacks up. People look at that and they say, ooh, not good. And guess what? We get this in the mail. They send us. They say, according to the doctors who your peers, this is where you are. I think Dr. Smith is like way up there in the state. So I feel like adults with sickle cell disease have a second medical condition. In some, it is just, we can call it opioid dependency, but it is a second medical issue that needs to be addressed. It's the fact that they are going to need opioids until they die, and we don't have a good alternative. And the more opioids we give them, the more opioids they will have to take. And we're leaning in towards calling that picture bad. So that really is another completely separate medical condition, medical conundrum that patients are having to deal with. And I feel that when we think about treating sickle cell disease, starting with children, we should think about what is life going to look like when they're 30 and 40, because we now have the ability to get them there. And what can we do to make that 30-year-old have to use less opioids and still be functional? And I feel that that is, when it comes to drug development and treatment development, that is as important. Because having to be on opioids isn't something that patients want. They don't want to be constipated. They don't want to be sleepy. They don't want to pop all these pills. They don't want it. But that's the only thing we have to give them to make their quality of life what we want it to be. So what we do is we try to do safe prescribing. We try to tell our patients, limit who gives you prescriptions. When patients get discharged from the hospital, initially it irritated me when the residents and the hospital doctors did not want to refill their opioids because it was too high. But now I appreciate not having them refill it because it's just one less doctor on my patient's rap sheet. Because that's what it is. It's a rap sheet. One less patient, one less provider that they get dinged on. So I'm very happy when I get that phone call and says, can you refill their meds? They're ready to be refilled. I said, I'll gladly do it. So trying to limit who's prescribing, trying to limit which pharmacy they get it filled at. Giving patients a really robust education on the risks of opioids so that they understand what the risks are. Doing a urine toxicology screen to make sure that they aren't doing something else that increases their risk of having an overdose. To make sure that I can say, yes, this patient gets enough opioids to kill probably half the people in this room, but they take it, and I can prove it. So that when I get that call from the pharmacy, or the Board of Medicine sends me a letter saying we're questioning your prescribing, I can have an answer. And I started doing this because I felt forced to do it, like I felt I needed to do it to cover my butt. But then I realized I need to do this to protect my patients. because the system is going to come after them. We have insurance companies simply saying, you have to cut down the opioid. We have pharmacies simply saying, we are not going to prescribe. I don't care what doctor writes what on that prescription.
So you said earlier, everybody is using some type of drug.
Yeah, I was being a little bit.
No, but,
yeah.
but tongue in cheek, but
Yeah.
also very fair.
Yeah.
For your urine toxicology
Sure.
screens, I have patients who feel as though they are criminals in a way when they ask for a urine toxicology screen, and then they may pop positive for something like marijuana or something else. How do you go about that? What is your role in playing that and kind of, I guess, seeing that process through? Because I think also patients may be using these drugs as, like you said, as a coping mechanism. They feel maybe I can smoke just to feel a little better. This becomes a part of their everyday lives instead of like being overusing opioids. They're just overusing something else.
Okay. My practice has changed, and it changed fairly a while ago. I don't bat an eye when I see marijuana in the urine toxicology screen.
So, sorry.
Yeah.
So to go a little further, how would a CBO go about having those conversations with other doctors in other facilities? And and advocate for that. Yeah, exactly. So for someone, this is going to be a primary. This is a primary theme for me.
Yeah.
This institution, this is an outlier. And I appreciate everything you all are doing, and it's something that you are laying the blueprint for, but this is an outlier, and not everybody has these resources. So I'm trying to figure out what are the proper ways of advocating and having these difficult conversations with these providers who aren't maybe as understanding.
Yeah.
Right.
So, go ahead. Were you going to answer?
If you look at what's being prescribed for other patient populations with chronic kidney cancer, for instance, they're getting Maninol. So what is the difference between allowing them to use that to help manage their pain versus, okay, so they may be smoking pot, but that's basically what they're trying to get the same benefit from that pot that the cancer patient gets from that prescribed Maninol. And I think one of the reasons why Dr. Lopato has changed his mindset, and that we all need to, is to start looking, stop thinking in terms of that's a illegal substance, and thinking of the medicinal benefits that patients receive from that. And he has said, if his patients are taking marijuana, smoking pot, and they're stable on their opioid doses, and we're not seeing them in the ED all the time, I'm there. You have to pay. So I think it's those kind of conversations are going to have to become more frequent, and with the crisis, it's going to force us to have those conversations and start looking at all those other. I mean, that's the whole reason why we're looking at having medicinal pot.
Right. No, I understand and also agree with that. My thing is, but what if that isn't?
Yeah.
What about those institutions that?
I mean,
what about those doctors that aren't doctors?
I have had conversations with residents or inpatient doctors, or even doctors in my primary care clinic, and I've just had frank conversations that sometimes I'll cover the resident clinic, and they'll present a patient who has marijuana, and they want to stop their opioids, and I would tell them, no, don't do it. I think that this wave of legalizing marijuana, while there's some issues on that side when it comes to potency, because it ain't the same stuff that the hippies smoked, that's a different story. But I think that wave of legalization will force the medical community to really change. Because when if it's legal in the state of Colorado, then how is a doctor going to say, I'm going to, so I think that's going to change. But you're right. It is something that that I feel it's my role to push back when I hear doctors or anybody saying, well, they have marijuana in their system. And I just frankly say, I don't care. And I also go the extra mile and I say, if it's helping with their pain, they should smoke marijuana. Because I'd rather them smoke marijuana than have to take another extra oxycodone. Yes. Yep.
Kyle, I would just like to say, for the other, to bring around other providers, I would say for all advocates to start where it's legal. That's your best bet. It's all going to come around. I think the entire country is going to come around to legalization eventually. But for advocates, start where it's already legal.
And I think my issue with that, I totally agree. I think my issue is that patients feeling this is another way for them to feel as though they are looked at as a criminal and not as a patient. You know, it's just another stigma being placed on them. And it's hurtful and, you know, really just creates more of a stringent gap between provider and patient relations. So I just wanted to put that out into the atmosphere and so that we all can acknowledge it, that it is happening and continues to happen. So.
We're going to keep going until about 12:40 with Shirley's permission. And we're going to keep the conversation going. I want to add to the conversation. Dr. Pato is not going to sit down. We're going to keep going, talking about what I call the difficult patient. And we see these patients in our emergency departments as a rule of thumb. It's all about culture, it's all about presentation, it's all about implicit bias, external trappings that produce beliefs. And we make assumptions about those patients, especially when they request a specific dose of a specific opioid, and people go, really? And you just, it's not morally appropriate to do that, but we're doing it. And so this has been written about. This is an article from way back in 2009, but even since then, there have been articles written, and I think yesterday somebody talked about an article on the difficult patient. I want to play you an audio here. Let's see if I can get this working, Daniel. Just click on that.
Later, Prodigy would call this judge the most racist judge in Nassau County.
Actually, he calls him Archie Bunker.
But I asked Risco if racism is what she saw when she was in that courtroom. She shook her head.
Maybe he just thought the kid was full of crap. And let's face it, he was no angel. So I can't say why the judge acted that way. I can't say it was racism. It could have just been ageism. I'm old, you're a rap, but I don't like rap.
Risco says, just think about when this trial was taking place. It got started just as Tupac was killed in Vegas. And by the time it finished, Biggie was dead too.
Rap wasn't exactly positive back then. You might as well said rap, criminal. So it might have not so much been about race and more about he was a rapper and he was young.
When this judge looked at Prodigy's medical records, he saw something really different than what Risco saw or what Prodigy's lawyer saw, any of those lawyers arguing in front of him. So I asked someone else totally to translate these documents.
Report.
So you can read them. I was like, I don't think
Yeah, I can read it. Scratch, but I can read it.
His name is Dr. Wally Smith. How long have you been treating sickle cell?
I've been taking care of sickle cell since 1984.
Dr. Smith researches sickle cell, and he takes care of about 400 patients at Virginia Commonwealth University. Yeah, the early ones seem to just say walk out.
That's what that meant? Walk out. Couldn't read that word. Left AMA. Yeah, that means he left against medical advice.
So in these records, you really can see inside P's body. He keeps getting these bone scans scans his clavicle, his left leg, his right arm. All of these bones are severely damaged. He has what's called fishmouth vertebra, which is when your backbone is literally wearing away. One doctor told me, like, it's kind of like they're rotting.
Yes, that's a good word. Rotting is a very good word. Truly is occurring in every long bone, all over the body.
I asked Wally to explain just what was going on here, and he said you can think about what's going on in Pete's body, sort of like a heart attack, but in your bones.
It means no oxygen is getting to the bone. It's a deep ache. Myocardial ischemia is what leads to a heart attack. This could be thought of as a bone attack. It's just no pain like you've ever had before. It's gnawing, it's deep, doesn't go away until the ischemia itself goes away. That can take days or 2 weeks.
Pete was also getting something called acute chest syndrome. This is one of the worst side effects of sickle cell. It's actually one of the leading causes of death in sickle cell patients who are his age.
Acute chest is basically a crisis that occurs in the lung itself. The blood vessels of the lung essentially get sickled blood in them.
Tell me about that. If he had 4 instances of acute chest, what does that mean?
That's a harbinger of bad things to come. Each one of those could have killed him.
When you listen to Prodigy's music, one of the things that he is known for is being a storyteller. And then you look at these medical records and you see his body breaking down. It's a whole other story about Prodigy that most of us don't know.
Can we talk a little bit about, at this time, 95, 96, he's early 20s.
22. Yep.
What is that time period like for someone with sickle cell?
It's hell.
The first time I talked to Dr. Smith, he told me that one of the biggest problems with being a young adult with sickle cell, someone like Prodigy at this age, is that you're just not cute anymore, the way you were when you were diagnosed, when you were just a baby.
They lose their insurance. They move out of the house. They're into it with their parents about their behaviors. Boy, you gotta stop all that drinking and smoking. Don't use those drugs. They stop going to the doctor. They think they're invincible. Take sickle cell away from it. This is just normal adolescence. Throw sickle cell on top of that. And it unfortunately is not uncommon for them to die.
It's not uncommon for them to die?
I'm making a statement based on facts, ma'am. I've got the records and the studies to back me up.
I asked Dr. Smith to look at one last record with me. It is A268 at the top of the page. It's a little chicken scratchy, but
It is.
this is from right before Christmas, 1996.
Social history, ex-smoker, denies intravenous drug abuse. Doubt that very much. Patient is non-compliant and has no regular primary medical doctor. Comes to hospital frequently for morphine sulfate for pain. States only morphine sulfate helps.
So when you see these kind of comments, what do you think about that?
Prejudice.
That's a strong
It's prejudice. It's prejudice. Let's analyze that term, non-compliant. That's a pejorative term. We don't use that term anymore. It implies that you made a rule and that they broke the rule. Another pejorative statement insists that only morphine sulfate helps. Well, most patients have been experienced enough with their pain to know what works for them and maybe even what dose works for them. It doesn't help that he's a young black man. It doesn't help that he doesn't have a doctor who knows him and can vouch for him. And it probably is true that he is defiant and oppositional when he comes to the hospital because he's expected that he's going to be treated badly. And so it just, nobody's trusting anybody. That's what I read into all of this. If I'm wrong, I'm sorry, but that,
Makes me want to cry. Yeah, Prodigy was a thug probably and a rapper and all that. But it wouldn't have to be, that wouldn't have to be Prodigy that we just heard about. Those are our patients. And so what we're saying to you is we have a culture war here in addition to a medical war going on when we try to treat adults. They're not cute anymore. And so they take on these cultural trappings. And is it any wonder that they have to dress up, put on nice clothes and lipstick in order to get treated right? Because if you don't, people read into that. And let me just say, black doctors do too. The research suggests they are worse. The research suggests worse, nurses are worse than doctors.
Oh, yes.
So what should we be doing for these patients?
Later,
What we should be doing is treating their acute pain with a pain action plan so that they have what they're supposed to get on a non-pain day. They know what they're supposed to get. And then on a pain day, they're going to get more. And you can figure out what that is. Every patient can have an individualized pain plan that says on your pain days, this is what you start out with. This is your base. And it doesn't have to include opioids. And on a crisis day, I'm coming to you, on a crisis day, more. Add something to that. Maybe you stay off work and get an excuse from me. Maybe you don't come to the emergency department. I didn't show you the slide, but most people do not come to the emergency department for their crisis. We talked about that earlier. And then on a hospital day, when you sort of say, I give up, okay, now you probably need a shot, you need some IVs. And we have something in the hospital called a tiered oral therapy program that even in the hospital allows you to get mostly oral medications, but it's hot and heavy, one right behind the other. And we are able to demonstrate that we can almost replicate, and Justin's here, Justin's one of the nurses on the floor where we roll this out. We can almost replicate the pain relief that you would get from shots using the tiered oral therapy program. We were able to reduce the length of stay. It's in your annual report that's in your binder. On Justin's floor, we were able to reduce the length of stay using our tiered oral therapy program. Just somebody paying attention to the pain. That's the principle. You pay attention to the pain and you get on top of the pain. Almost doesn't matter whether you're giving a shot or giving pills. What matters is you're going up repeatedly. And Dr. Lopato, you want to talk about the total requirement that you would expect from that kind of approach as opposed to just doing the same thing over and over again for a long period of time?
What do you mean by
A total opioid requirement over, say, a 5-day period. Do you expect it to be higher or lower is what I'm asking?
lower?
It's going to be lower.
Lower, yeah.
Why is that? Because there's something called the wind-up phenomenon that happens in the brain. When you do not get in charge of that pain, on top of that pain early on, the total volume of pain actually goes up. When you get on top of it earlier, with a higher dose earlier, you wind down. And that vicious cycle goes in a positive direction instead of a negative direction. So every patient should have a pain action plan, should be individualized with their name on it. And you have to come at that with time. And Micah, you want to come talk about your job and what you do? One of Micah's jobs is dealing with these individualized pain plans.
Hi, I'm Micah, the inpatient nurse practitioner. I think I met most of you yesterday. Most of my dealings with patients is in the hospital. So I am actually sort of in between crisis day and hospital day for most of our hospital utilizers. So their individual treatment plan consists of, it has their ED plan. So I usually sit down with them and figure out what works, what doesn't, what doses work. Should we go up? Should we go down? Because I don't want to give you too much medicine. In conjunction with orals, we try to start them in the ER. I will then translate that into a inpatient plan, should they need it, using our tiered oral therapy for most of our patients, now that it's kind of going hospital-wide. And then it does include their outpatient management as well, so that we know if they're there for a prolonged stay, what we need to potentially taper to, are they taking them routinely at home, and whether the NSAIDs work, what adjunctives work, et cetera, whether they benefit from fluids or don't, because some of them actually say it doesn't really help them.
Yeah.
And it's individualized per patient. Every patient that I've done has one in their chart labeled sickle cell treatment plan, and they're all very, very, very different.
And maintenance is a bear.
You do have to maintain them, and sometimes they're changed weekly, which is tricky, but yeah.
So that's what her job is to do that, so that every time, every patient gets the most updated version of their plan. And Dr. LaPaula, do you want to talk at all about what you do and what we do in our case management and how we change the plans based on some of the behaviors? And then I'm going to sit down so we can have more discussion.
So when we have a patient that is exhibiting problematic opioid use, we will oftentimes accept what the patient is telling us, and we will significantly increase their opioids. And we'll do it, obviously, closely monitored, see them back frequently, to see if simply having more opioids allows them to just better manage their pain at home, and that they don't then have to come to the emergency room day after day after day. We've done that on several patients. And when that fails, and is individualized as far as how long we try this course, and I would tell you that we do this being rather fearing for the patient. Because if you're worried about misuse, the knee-jerk reaction is to cut it off. We tend to pivot in the opposite direction and give more, to see if it changes that negative behavior that we're concerned about, to see if they're just not getting enough of their pain meds and believing them. And if that doesn't work, then it's a hard conversation. And some of the options are trying to pare down their outpatient regimen and do it in conjunction with what they get in the emergency room. So let's say if somebody does have an opioid use disorder, or they're just misusing their opioids, and I cut down the opioids in the clinic, they can just go to the ED and get a whole bunch of opioids. So we try to pair that cutting down or ramping up on both ends. And obviously that gets pared down or up on the inpatient side as well. And that's where Micah is very important, on the inpatient and the ED side. And then if it gets to a point where we say, no, having you on an opioid is not safe, then we have transitioned some patients to Suboxone. And to answer the question back there, do they like it? We haven't done it long enough to see if it works. No, they don't like it. Just the easy answer. They don't. But I think that the use of Suboxone, buprenorphine, we are going to start using it more, and probably thinking about using it more even in patients who aren't problematic or have problematic use, but using it more to see if what the literature says is true. It says it is a pain medication that is as effective as a pure agonist opioid, like morphine, but it has less of that respiratory depression. So if I increase the dose, you're not going to zonk out. And so we're thinking about really trying to prescribe buprenorphine more, both for patients that we're concerned with their use, but also patients who just maybe need to be rotated from one opioid to the other. But that is really something that we are working on. There isn't much literature about it. Almost every week I try to go in to see if there's something new. Sometimes there is, sometimes there isn't. Do you want to add anything?
You covered it.
All right.
Can I ask you?
Yeah.
How do you, well, one thing, do you all also prescribe Benadryl for itching or for those who have those side effects when they're giving IV opioids? And then also, how do CBOs advocate for those who have these individualized action plans, but they travel from state to state or city to city with their action plan, and then the doctor in that city that they go to if they become sick doesn't honor that action plan, or or even if they call their doctor, they still don't feel comfortable, going.
So I can address this. Our patients are allowed to get oral Benadryl as an institution. Oh, thank you. We have moved away from IV Benadryl for safety reasons. They can also use other antihistamines, hydroxyzine, famotidine, loratadine. Any of those should have a similar mechanism of action. We do not use IV Benadryl because it can enhance the effect of these high doses of opiates, and it can cause oversedation, and it's just not safe. So our policy, inpatient at least, is only for anaphylaxis or blood transfusions. In the ER, they're a little bit more lax, but we're moving away from that. As far as the individualized treatment plans, though, the patients are allowed to have a copy of it. I cannot make any other provider follow it because they do get very anxious about these high doses of opiates. But I can encourage them that this is what they get when they come to our institution. It has been demonstrated to be safe. This is how we do it. This is how we dose stack, which is a big no-no in medicine too. This is a patient population that benefits from it. Usually a nice conversation. They usually feel pretty comfortable. Now, some smaller hospitals have caps on how much opiate they can get, which gets tricky with some of these patients. So if you're a patient who gets 12 milligrams of Dilaudid times 3 or 4 in the ER, but their institution says they have to give that over 20 minutes, it's not helpful for that patient. So it gets tricky. Yeah, but they can have a copy of it, absolutely.
I have a experience with a patient for over a year and a half experiencing pain and going to the emergency room. And they made the assumption that this person was a drug seeker and constantly sent this patient back home, wrote the prescription, when really did not do a thorough medical exam. Well, after a year and a half of going back and forth to the ER, somebody just got real stern and said, we're going to find out, because this is not this patient's usual pattern of behavior to be in pain, period. And for a year and a half, this many visits, when it came down to what the patient needed, they had an underlying medical condition that any of us probably could have suffered, but because that person had sickle cell, they assumed that they were a drug seeker. This could have cost that person their life. And it's just that I don't know what can we do to combat these attitudes and these assumptions and these treatments of prejudice when they're in the emergency room. And this person, unfortunately, occasionally dress hood, went to the emergency room, didn't dress up, didn't put no heels on, no makeup on, wore the head wrap, like people would say, oh, they look like hood. Yeah. And so, I don't care what you look like, you come in the emergency room, you're sick.
Yep.
And you need the help and care.
And I agree with you. I think that we're fortunate enough with our program to have a lot of resources that I feel like a lot of other institutions don't have. Mm-hmm. I'm going to give most of the credit to those two in the back, our patient navigators. Mm-hmm. I mean, they will hit the ground running. They're there. They're having these conversations with patients when the providers can't, because sometimes they don't want to tell me that they're out of medicine or that they feel like we're missing something. Or sometimes it takes a couple of visits for us to get to the bottom of it. And I know how many patients have come to see you guys in clinic and they don't want to tell you what's actually happening, that they lost their house or whatever it is. I think continuing to have the conversation, the dialogue, educating providers. I've sat down with ER docs, meeting after meeting, informal session after informal session, the nurses, to try to just have conversations about what are the concerns, why are you worried about that 12 milligrams of dilaudid, whatever it is. And it just takes time. I mean, I've been with this program one of the shortest times. I've been here for a little over a year and a half, and we're just now getting to a point where I feel like the ED is, they call if they have any questions, they call if they have any concerns, they don't assume for the most part. So it's just conversations, dialogue, advocates, if you can.
I think we have to break for lunch. Although before we do that.
Yes.
I want to thank all of our presenters on the pain. I know this is such a critical issue for all of us, and I hope we can continue some of our conversations. So thank you. Just one announcement, lunch is ready. We're going to do a couple quick giveaways. And those of you that need vegetarian, would you please just let your server know that when we get over there, because it's plated over next door, okay? So let's do a couple quickies. Oh, is it ready to go? Oh, where is it? Oh, there it is. I couldn't find it. Catherine Neal? Yeah, I don't think she came, so yeah. We'll try again. You can do it, Daniel. Go for it. We got to give away at least one. Azizi Coleman? Yay, we got a winner. Come pick you a pretty bag. All right, let me remove. All right. Now see, click that time. It took it. All right. Is Shamika Mosley? She's here? Oh, she's here. You'll get it. Okay, you'll pick one out for her. Okay. Let's do another one, real quick. I know she's here, but it's not on hers. Camille Radford, we got one? Great. All right, one more. Then we're going to go eat. Oh, they didn't tell me when to start back up. Oh, we just did that. Did we just do? Do one more. Let me do one more. I think I heard it click that time. I think you have to really hear it, and I think that's what I was. Oh. Creekmore? Oh, good. All right. Okay, we are in, I think we're going to run a little bit over. We're going to give you at least 45 minutes for lunch. We're going to cut it a little bit short so we don't miss all this good information we're going to get this afternoon. So go enjoy lunch, and we will let you know when we're going to come back. It'll be, I think, at least 11 to 1:30. Okay. All right.